This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Breaking the posterior plate in a brown or black cataract like this is a challenge, and we are using a technique called as flip the base up and Phaco. We presented a video based on this concept at the ASCRS 2025, which went on to win an award at the same event. So this is one such case where we'd like to demonstrate that particular technique, and let's see how things turn out. Now, she's an 80-year-old lady who has this brown cataract. It's about maybe grade 5, grade 6 nucleus. As I always keep telling that, one of the main challenges is visualization. We have the entire background is dark, and visualizing the capsule and other details become very difficult. So getting the rhexis right is critical, and we want a large rhexis in this patient. So the capsule is stained and the chamber is pressurized with a dispersive OVD. The blue capsule against a brown or a black cataract again is a challenge to visualize, but still something is better than nothing. The main 2.8mm incision is created and time to perform the rhexis. And I'm using the Haldi Puka forceps to puncture the anticapsule, raise a flap, and then the flap is grasped and the rhexis is initiated. My goal is to perform 5.5 to 6mm large rhexis. A large rhexis is helpful in such dense cataracts because the nucleus division maneuvers are going to be stressful in the bag, and if you have a large rhexis, the amount of pressure transmitted to the capsulorhexis margin in the bag is minimized. So we have got a decent sized rhexis. Time to perform a very gentle hydrodissection. It's important to note that the posterior capsule would be very thin in these long-standing eyes with brown cataracts, and I need to use as little fluid as possible. So the bag chamber is first decompressed, and the very little amount of fluid is just irrigated to achieve hydrodissection. The capsular bag is decompressed by pressing the nucleus down. The nucleus rotation is confirmed, and now is the time to deal with the nucleus. So as always in these denser cataracts, I prefer to use the 4-quadrant technique to deal with the nucleus, simply because it is much more predictable and safer. And this has become a technique of choice simply after the availability of the torsional ultrasound. So the presence of torsional ultrasound ensures that we don't have any wound burns, which is a very common sequelae when we use excessive power in the machines which are having just the longitudinal energy. So time to perform the trenching. The nucleus is stabilized with my second instrument. It is a sharp chopper. So after about 2 to 3 sculpts, I'm going to rotate the nucleus to 90 degrees. The second trench is being created now. So please also note that I've extended the tip of the needle a little bit. The exposed part of the tip is slightly longer. This ensures that I can have a good reach as posteriorly as possible and also as long as possible. The nucleus is then rotated and the previously done trench is now being deepened. So at every rotation, we're going to have a trench which is slightly deeper than the preceding trench. So I'm noticing some conjunctival ballooning, so I'm just giving a relaxing cut in the temporal part of the bulbar conjunctiva and a little bit snip near the incision as well. So this ensures that there is no fluid accumulation in the conjunctiva and my visualization is not hampered. So time to perform the last trench. I prefer to do the trench with the bevel up position. The nucleus is then stabilized with the second instrument. This is what I would like to teach to all my residents as well. So learning to use a second instrument to just support the nucleus does come in handy when you're dealing with the mobile nucleus like a mature or hypermature cataract. So when the nucleus is being sculpted, it is held in place by the second instrument at least a bit. So now is the time to assess the depth of the trench. So I'm going to keep a close eye on the transverse striations which are perpendicular to the direction of the sculpting. I'm able to see them now, and the moment they fade away a bit, that would be the time I would like to consider attempting the lateral separation maneuver. So in these denser cataracts, these transverse striations are seen up to 90% depth of the nucleus. So I need to patiently continue sculpting until I have reached a position where the depth is almost 90% and is indicated by the gradual fading away of the transverse striations, which were very visible a couple of trenches before. So typically we see these trenches appear by 20 to 30% and persist maybe beyond 80 to 90% in these denser cataracts. So just I'm trying to visualize whether the striations are clearly seen or no. I just go in and deepen the trench a little bit more, because the single most important reason for a failed lateral separation is inadequate depth of the trench. So I feel this is good enough and I'm attempting a lateral separation. Unfortunately, I realized that this depth was not good enough. As we can see, the peripheral part has separated, but the central posterior plate is refusing to crack. I come out, refill the chamber with OVD, and then I'm just trying to redo the lateral separation maneuver. So I'm using a slightly longer Sin's cuke. Before that, I would just want to redo the sculpting a little bit, just to go in a little bit deeper. Again, the challenge is the poor visualization. In these cataracts, we all don't get the typical red glow which we can rely on. So I'm just relying on the striations, and the striations are now barely visible, but still the posterior capsule is very, very tenacious. So I'm just trying to deepen the groove. So now I see that there is a slight change in the color, at least in the peripheral part, suggesting that the nucleus has thinned out a bit and it could be the right time to do the lateral separation maneuver. So again, I go in with a slightly long chopper here and I'm attempting lateral separation. The Phaco tip touches the base of the trench, as does the second instrument, and then I'm attempting lateral separation. I'm not being very aggressive and I'm using multiple attempts to ensure that the fragments are separated, trying to be as gentle as possible. So again, the second part I'm trying to separate, it's not separating. So I'm just redoing the sculpting a bit, just to thin out that area so that the lateral separation maneuver can be easy and automatic. So let me try it now. Unfortunately, it is still refusing to crack. The peripheral part is okay, but the central part is not budging. So I'm just trying to engage the nucleus with my second instrument and then perform this chop-like maneuver. So eventually this fragment is now totally clear. So I rotated the nucleus now. So if you are unable to get it right by the lateral separation maneuvers, we can use a modification of the chop where the tip is buried into the nucleus and the second instrument is used to do the chop lateral separation maneuver. The nucleus is engaged and the chopper goes down right up to the posterior plate, but still the central part of the posterior plate is refusing to budge. So the surgery is continuing and I'm going to redo the grooving here. Assessing the depth of the nucleus was tricky. So we thought we'd already reached the posterior plate, but now we realize that we haven't. Again, a little bit of more sculpting and lateral separation maneuver. So even after all this deeper sculpting as well, the central part which is holding these four fragments together is still holding them. Only probably one fragment is free. So these are the situations where if you panic and try to do excessive lateral separation maneuvers, there's always going to be a risk of capsulozonular complication. Most likely a posterior capsular tear can happen. So in such situations, we would like to propose our modification where we call flip the base up and Phaco. So now we have a situation where one fragment is free, whereas three fragments are still adherent at the central 2 mm zone, that is the posterior plate which is holding them together. So the strategy here would be to remove one fragment out and emulsify it first. By doing so, we are creating some space within the capsular bag. This ensures that when you want to flip the remaining nucleus, it would be easy. So the first goal is to create some space. So that's how it is being achieved by performing fake emulsification and removing this quadrant. So once this quadrant is out, now is the time to deal with the three quadrants which are adjoined at the center. So OVD is injected under these lens fragments. It's looking very deep, very posterior, but still I could somehow manage to go in with the OVD cannula, push OVD inside and lift the posterior plate up. It's basically like flipping up the nucleus upside down. The most posterior part, central part, has come anteriorly now, and the bridge which is holding these three fragments is in direct visualization. So using continuous torsional energy in the sculpt mode setting with low flow rate and vacuum, the bridge is destroyed in a very safe, effective manner. The moment this bridge is detached, all the three fragments are separated. They're pushed back into the capsular bag and then removed one by one using the conventional technique. The cortex is then aspirated out and the planned intraocular lens is placed into the bag. So these are the first day post-op pictures, and these are the subsequent follow-up pictures. So eventually the patient did well, the cornea is clear, and it's important for us to remember that the corneal endothelial damage happens predominantly by the use of mechanical forces, lens chatter, working more anteriorly rather than the phaco energy per se. So what we did differently here was, when the posterior plate was refusing to crack, we never pursued to crack it in with aggressive forces. We ensured that just one fragment was free. The strategy here would be to remove one fragment out and emulsify it first. By doing so, we are creating some space within the capsular bag. The nucleus can then be manipulated in a way where it's easier for us to do so, and then the posterior plate, which is holding these three fragments together, is pushed out anteriorly using a visco cannula. It comes all near the rhexis margin. And then this bridge which is holding these fragments is carefully destroyed by the phaco power in a continuous torsional mode with very low flow rate and vacuum. So this is a very consistent and predictable way to break the posterior plate in such situations. So once the fragments are separated, it's easier for them to be aspirated one by one in a controlled manner. So the next time we have such a situation where dense cataract in the posterior plate is not breaking, somehow managed to get one piece out of the bag, and the remaining three quadrants are then pulled up with the posterior plate facing anteriorly, which is emulsified using a continuous power in torsional mode using very low flow rate and vacuum. So this ensures that there is no turbulence as the bridge is being broken. Once the bridge is broken, you push back the nucleus into the capsular bag and then pull out and emulsify one by one in a very controlled manner. That was it. Thank you for watching and hope you found this helpful.